Dr. Vasudev, organizers of this meeting. At the outset, thank you very much for giving me this honor to speak on this Dr. Boppaiah endowment. I have met Dr. Boppaiah on many occasions in Bangalore, and I am aware that he is a very well respected, very senior pediatrician of the country, and a very humble gentleman. And we heard Dr. Parmesh talking about Dr. Boppaiah. I'm immensely thankful for this endowment lecture that has been bestowed on me. The topic that I was given to talk on, which was not my choice, and I know that Bangalore Pediatric Society has always given some topics which make me sit back and think, and they know that I must have done many mistakes, so why not? Conditions offer myths in clinical practice. I asked Dr. Kasi whether he has missed some part of this statement. Conditions often missed by you in clinical practice. But I'm sure all of us have missed many things. And we heard Dr. Raghupati telling us how hypothyroid could be missed and diabetes could be missed. But I also know that many of us must have missed normal children and called them abnormal. I think that's another spectrum of what we have missed. And I think I'll take you through what I have gone through last 40 years and how I looked up at the situation where things were missed in clinical practice. And I thought that that is a lesson that we would learn, that lest we forget, let's see what really we have been always missing. If I were to enlist the conditions that we have missed, then I think there are many, and almost everything in clinical medicine could have been missed. And I don't think I'm going to talk on conditions that we have missed. But I would rather talk on why did we miss those conditions. And I think if we only understand that why we have been missing things, then probably things would get in order more than just enlisting the conditions. And I always felt that we never missed conditions because of ignorance. We probably knew enough, but even then we missed. And I think that's a pity. And Dr. Raghupati mentioned a condition missed by well-trained pediatricians. So where is the ignorance? There is none at all. And even then when we missed. And I thought the commonest reason that we missed that as we got on to postgraduate and consultant level, we left our undergraduate training way behind. And we almost thought that we can do many things without those well-trained protocols and the rules of the game. And I think often it was an inadequate history. The parents were pointing out very clearly only if you bothered to inquire correctly. We always had a hurried, improper physical examination. Some of us in clinical practice are lucky not to have developed a large practice, in which case you spend a little more time with the patient, lest you don't know what else you do otherwise. You come home a bit late, your wife is impressed by the amount of work that you have. It's only later that she understands that you're not made much anyway, even when you spend time. But that has helped because you're never in a hurry and the examination is often proper. I recall one of my teachers who went to UK to do his membership, and when he was a resident there to be enrolled, he was being examined for fitness as a resident. And the British physician took half an hour to examine this normal, young, fit graduate student, and he even tested his sensations and cold and hot and so on. And at the end, my teacher asked him, why do you do all that? And he said, don't you examine patients like this in India? I think that was the message, that even to be sure that he is a normal person, he would examine him thoroughly. And I think many times the mistakes have occurred simply because of that. We many times have ignored standard rules and protocols which have been well set, and only if we followed them, probably we would not miss many things. At times we have given inattention to disturbed physiology. People have diagnosed pneumonia but killed a patient of hypoxia, and people knew that was simple diarrhea but somebody died of something else. And I think at each time what kills a patient is the disturbed physiology more than his etiology. And And I think many times the conditions were missed simply because of that inattention. Finally, I think because of several issues, we developed more analysis and interpretation activity in our mind. And I'm sure if you are a very busy practitioner, you have almost stopped thinking, you have stopped analyzing, you have stopped interpreting, and over time the whole process rusts, I suppose. Like most of the adults we heard in the first lecture in South India, they have a lactose intolerance because they've never been exposed to milk over years, and the lactase enzyme gets rusted. And I'm sure many have rusted their ability to analyze and interpret. And finally, we have some misconception of basic facts that have been quite deeply rooted in our brain, and we don't seem to come out of it, and we just simply follow it. And I thought when I analyzed the reasons why we miss many things, these were the reasons. And I'll dilate on each of them, giving an example of how and what happened if you did not attend to all these factors correctly. I'm sure inadequate history is a rule more than an exception. And many times if I'm asked to now give a second opinion, I feel comfortable not to listen to history by my pediatrician colleague, but get to the parents myself, because then you get all the details that you had in mind to go by. I think attention to details is so much a must that all of us have undergraduate days learned the history taking, and each point like say keep complex. Subsequently the origin, duration, progress of each symptom, and the other components of relevant history that we've all gone through. And I'll give you examples of how one would miss easily if you just did not follow what we have been all taught to begin with. Each of these points then we realize are so vital and important in the ultimate making a correct diagnosis that we can't easily get over it, especially if we don't understand what the problem is. Then it's much better that we go very, very methodically, and each of these points in the history becomes very, very important. This was a year-old child who presented with recurrent fever, cold and cough since the age of 3 months, and he was not growing well. Naturally, those who would give a very casual look at this history would almost come to a conclusion that this is something of a serious nature disease, that it has been happening repeatedly ever since early infancy, and the child has failed to grow. This child was admitted for bronchopneumonia at 3 months of age, and that's where the whole story started. Naturally, considering superficially that this means something very, very much in the background that you need to find out, studies for GES, studies for cystic fibrosis, studies for immune deficiency, everything was ordered and normal. What was missed was when you get into the details to ask the parents were illiterate but not ignorant. And I think even illiterate parents would know to answer your question correctly only if you knew what questions to put up. And when these parents were asked what was the predominant symptom, it was never fever but the cough all the time. If the child had never much fever, fever was occasional, in which case you knew that this could have been probably even a non-infective condition, as there was no fever at all. And finally, what was being considered as not growing well, there was never an attempt to chart the growth parameters. And when we charted that on the growth chart, even when there were few measurements available at some stray points, you could see that the child was born and was maintaining 5th centile all through. And therefore, it was not also that he was not growing well. If we did not consider this correctly, that this child had just a hyperreactive airway and a strong family history of atopy, surely this child was being considered as one of infection and being considered for studies like CF or an immune deficiency. A point that I want to make strongly is that a chief complaint is so vital, that here was a child with fever, cold, cough, but you did not take all three together and you dissected them out. You knew that the fever was the least important, least accompanying symptom, and it was mainly the child with cough and the growth chart, as I said, which was so vital to be sure that there was no failure to thrive at all. This child was much smaller in weight, but had a reasonable padding of subcutaneous fat and a reasonable muscle mass. Therefore, it was just not the weight at one point, or height at one point, that made one consider that he had failed to thrive. And I'm sure Dr. Raghupati would endorse that growth charts are so vital that probably many endocrinological disorders which come with stunted growth can be only diagnosed by looking at growth charts. And you don't need an endocrinology laboratory to go by that, only you need to do that for confirmation. And if that is so, why should a pediatrician not have a growth chart plotted each time he saw a patient? This is how simply a given detailed history would make one commit a correct diagnosis. This was an 8-month-old child who presented with vomiting for the last 2 months. A physical examination, there was nothing, and many investigations were done normal. If a child vomits for 2 months, you have a GI series, you have a liver function test, you have a kidney function test, somebody had done a CT/MR of the brain and so on and so forth. Every concern about cause of vomiting was being investigated, but to no avail. This is a child who showed us how important is every component of the history. That if the first case taught us that chief complaints has its own value, this child taught us how personal history was so vital. And when we asked for the personal history, this child had marked anorexia. He was very irritable, difficult to manage. He was constipated. He was polyuric. And simply when I put all this together to a postgraduate, back came the answer quickly, whether it was a hypercalcemia. It would not have been diagnosed at all but for the details of the personal history. And we knew that this was a child who was being given a lot of vitamin D unnecessarily and had a hypercalcemia following that. And that was the cause of vomiting for 2 months. How important then that what we have learned over time that we have to get to even a personal history. And I'm sure earlier days, personal history meant are you a vegetarian or a non-vegetarian no longer exists. Once we had this child, I remember for a while, my registrar would ask for serum calcium anybody who vomited. And that was going too extreme. And therefore, again, importance that how even every minute details of the history would pick up something that otherwise even the investigation would fail to pick up. This much then on the history, and I'm sure every part of the history could be given an importance. And I know that history starts with asking the name of the patient. In Western world, if you did not ask the name of the patient that has a rapport, probably you started wrongly. And we all know we start with an age. And I recall a child who at 6 weeks of age presented with severe anemia and a hepatosplenomegaly. He was investigated. His fetal hemoglobin was 30%, and there came a diagnosis of hemolytic anemia. Everything looked simple, but for the age, that thalassemia never presents at 6 weeks, and therefore we knew that this was simply a severe malaria to it. The point that simply the age was not considered, you could have misled the diagnosis completely. What about the examination part of it? I'm sure that many times you may be in a hurry if you have a lot many patients to see. And over time then one learns how to prioritize, how to spend different timings with different patients. That occasional patient may need 30, 40 minutes for a proper diagnosis. Another one can possibly get through even 5 or 10 minutes. But there are some rules that we would like to follow. If we forget, then we are often in trouble. And I'm sure that the first visit to especially a neonate or a small infant would be so important that you would have to check things that are often missed. I recall a cleft palate being missed because to get to a cleft palate, you need to have an open mouth being seen. And that's not easy often in a neonate. Coaptation, feel the femoral pulses, which becomes probably a habit for every first visit or a small infant's visit. Dislocation of the hip, undescended testes, spinal dysraphism, cataract. Now, that may not be so easy, but an attempt to look at the eyes of a small baby. I recall a pediatric cardiologist who came from abroad, and he said that every time a newborn is discharged from a routine maternity home, as a pediatric cardiologist, he had learned to put 2 things on the paper, that he was seeing a P2 split, and there was a no right ventricular preponderance. He said that that was so important that if you had a child at day 3, day 4, whose pulmonary second sound was not split, as would be expected by them, you would almost venture to follow this child very closely for any pulmonary obstructive disease to come up, like a Fallow's, which would be obviously seen later. I think the point that I'm making is that some special emphasis on looking at these subtle points would make us not easily miss them. And I'm sure one has seen a dislocated hip coming at 2-3 years with a waddling gait and so on and so forth. I think enough has been said about growth chart, and I again would plead that every pediatrician must have a growth chart plotted for every patient that he sees. It is pity that as a pediatrician, I'm sure Dr. Raghupathi sees it so many times often and he must be getting upset with us. But you see a 10-year-old child for a child not gaining height and not even a single measurement of his length or height any time in his life. How would you make out whether he's short for what reason? Is he a constitutionally short? Is he a genetic short? Is he a syndromic short? Is he a pituitary dwarf? Is he a hypothyroid? I don't think it's easy, and going into investigation is not often feasible. And I'm told by endocrinologists that investigation like a growth hormone is not an easy situation. It needs to be done by an endocrinologist under a very supervised regime, and forget the days when you ask some lab to do some growth hormone at any time and just go by those reports. But for the growth chart, it all could have been just easily managed. And I think it's again very, very vital that we all have to have a head circumference, length, height, and weight put on the growth chart. And I think it is so simple. It is so cost effective. And I think many things would be made out very, very quickly. For example, I see a child who is not growing too well, but otherwise he is very active. He has no symptoms of any disease, and the parents are floating around to see why he is not growing well. It could be simply just a constitutional or genetic. And I broadly consider that health is measured best by activity of the child, and the growth is best measured by the length or height of the child. And weight is a poor parameter in the sense that you are happy if somebody doesn't lose weight, but you may not greatly get upset if the weight is not gained. And gone are the days, I'm sure, where you said 30 grams a day in the first 3 months. I think all that is foolish because it does not take into account a large variability that exists in the communities genetically and so on. And therefore, what best but to have the growth chart? And I think throughout the growing period, that means throughout our pediatric practice, a growth chart is an important point on the investigation, on your clinical judgment, and I feel we should never fault on using a growth chart. Besides that, it gives a lot of important interpretation for a clinician. I think it's very impressive to the parents, and parents are very happy to see the child growing. If the child is not growing, you are one much ahead of trouble, and you could pick up a chronic infection, you could see a deteriorating growth chart, and so on and so forth. And that is, I think, extremely important. Developmental screening is another issue, and we just heard a talk on autism spectrum disorder, and I'm sure each one of us, as a routine, in every child that you see him for cold, cough, diarrhea, vomiting, whatever. I think at an appropriate age to just quickly screen through a development of a child and ensure that that is within normal limit is very, very vital and important. And we all know how now an autism and autism spectrum disorders can be picked up by us at about 18 months, 24 months, simply because we give a little more credence to the development. And gone are the days when somebody doesn't speak till 3 years of age, and you tell him that, oh, your uncle or aunt also did not speak till 4 years and you do nothing. I think it's mandatory that by 16, 18 months, if you did not have a first word coming up, either you had a global problem or you had a hearing defect, or then you had a problem of one of the behavioral disorders. And I think it's so important to pick up an early developmental deviation. And even in a busy practice, it does not take a lot of time to quickly evaluate. If out of 10 children that you see in a hurry, if one is a suspicion, you need to spend more time on that, and 9 are past as just normal. And I think if you had required now a neonatal TSH screening, I feel clinical screening is a must. We are going beyond clinical screening to pick up abnormalities like hypothyroid much before even a clinician can make it. And here we are even missing a clinical screening method, and I think it's absolutely not right. There are some issues which I feel could be given a little more important by pediatrician in their routine examination. And like say amblyopia. For example, a lazy eye. If you get this in time, it could be very well corrected. Refractive errors, blood pressure. It has been now known that even benign essential hypertension of adulthood just starts somewhere in childhood, and it will be very vital to have a blood pressure record at least sometime at, say, minimum at school entry, maybe again at school exit. But we as pediatricians must realize that we need to take blood pressure of a normal child at least once to be recorded. Well, when it's a renal disease or intracranial disease and so on, one would certainly go by a need of blood pressure monitoring. But even routinely, this becomes important. And again, orthopedic surgeons are trying to now convince us to look for such deformities which could come in the way, not only cosmetically but even functionally. And scoliosis is one such. And I was told by a pediatric orthopedic surgeon that all that you have to do is to just take your stethoscope, put it at the occiput and see whether the spine and your stethoscope is hanging symmetrically. I think it is just a simple screening method, and I'm told that there are many children with scoliosis who come to them only when it is so advanced that they possibly cannot set it right. I imagine such simple observations would go a long way to make life a little more easy for the parents to go by. And this was a year-old child who presented with diarrhea for 3 days and breathlessness for a day. He was quite malnourished, he was dehydrated, he had a tachypnea, his abdomen was distended. He was considered to be acidosis, rightly so, because he had a rapid respiration in a child who is dehydrated and he could be acidotic. He was given IV fluids because we all know that if there is a diarrhea with dehydration, we don't need to treat acidosis with alkali, you just hydrate and everything gets back to normal. But this child did not, and what was missed was a poor cry, a hypotonia, muscle paralysis, hyporeflexia. And therefore what was missed was a severe hypokalemia. We all know now that if somebody is breathless and is not even able to voice, it is a voiceless breathlessness. It almost always means that the respiratory muscles are weak or paretic, and I think like a GBS or polio earlier days and hypokalemia and so on, a clue that is staring at you, only if you can just pick it up. And every breathless child by and large is making a lot of sound respiratory wise. You could have a stridor, you could have a grunt, you could have a wheeze, you could have something more of as if breathlessness is being voiced. And if this breathlessness was not even voiced, you clearly knew who would take a reflex deep knee jerk or look at the tone of a dehydrated child. But if you did not, even when you had this kind of a situation, you missed a hypokalemia and it could almost cause death. This was an 8-year-old child who presented with general weakness and breathlessness over the last few days. There was a past history of occasional wheezing. If you have a history of wheezing and if somebody is breathless, so you imagine you nebulize. You almost get that. Physical examination, no localization. The CBC chest X-ray was normal. He was nebulized and oxygenated. He was even, in spite of all that, he was worsening. And as Dr. Agupati showed us some time ago, this was a diabetic ketoacidosis. I'm sure that if some healthy child comes with an acute onset of feeling terribly weak, that is a pointer that something is terribly going wrong. And I recall a few times such severe general weakness. I remember a child who was playing a very competitive tennis in school, and his coach used to be after him to excel. And one fine day, he said, "For me, I don't want to go for my coaching today." He was being punished. He went to the court, he could not play. For 3-4 days, he was simply spanked because he has lost interest and is doing so good. And then came suddenly a drowsiness and consciousness, and you missed an initial symptomatology. It's a vague symptom, but it's an important symptom that no normal healthy child should come out with any time. And I'm sure we heard Dr. Agupati showing us different ways that diabetes could come up. And I recall this child who was for 5 days being treated for nebulization, x-rays, etc. When you have nothing in the chest to look at clinically, you know almost always it's acidosis. And if you have a bigger child with acidosis for no reason, I think the only cause probably is the diabetic ketoacidosis. And if you look backwards, it looks so simple. It's so easy. Only if at that time you have an ability to think, analyze, and interpret correctly. This is a 6-year-old child who presented with a gradual abdominal distension for the last 2 months. There was a liver, there was an ascites, engorged abdominal veins, and therefore a diagnosis looked simple as cirrhosis. Because you had a liver, you had a distended veins, you have. But for the fact that there was an engorged neck veins which were missed, and this child had a constrictive pericarditis, which looked like exactly cirrhosis. Again, a point that if you had a hepatomegaly which is congested, I think you have a possibility of an inferior vena cava hepatic vein congested. You need to look at the superior vena cava obstruction, and every child of a so-called liver disease with congestion, cirrhosis, ascites would have a look at the neck veins, and you could pick up a constrictive pericarditis. Here the chest X-ray would be normal, the heart sounds would be normal, clinical examination won't give any clue whatsoever, and it could be easily passed as cirrhosis because you have a liver disease with ascites, abdominal veins. And I think how easy is not to miss it only if you looked at the neck carefully in this child. And that's much about the history and clinical examination, how simple facts are overlooked. Not that we are ignorant about it, but we are in a hurry. We don't have a set of a routine to follow, and then we miss something which stares back at us too foolishly, and they say, how did I miss such a simple thing? Many times we ignore a standard protocols. I'm sure all of us know that in a given child of fever, if you do not have a diagnosis, don't give an antibiotic, especially in an infant or a young child. And I do not know which conditions when a child presents with fever on day 1 or day 2 that you can write an antibiotic, barring the fact that you may have an acute tonsillitis or an acute cervical lymphadenitis staring at you. Invariably, most of the febrile children in the first 2-3 days have no clinical clue of what you're dealing with. And if you're suspecting something serious, it is mandatory that you quickly at least go through a preliminary investigation, and I'm sure how often a UTI would be easily missed. And I recall a child who came at 2 years of age with failure to thrive, severe rickets, renal rickets, purely out of not a renal tubular disease, but out of recurrent fever and a recurrent pyelonephritis, being treated each time without a diagnosis to a point that he was in a chronic renal failure. I think atrocious to see how in a hurry simple protocols are not followed. Nobody has died just because you did not pick up a cause of fever in the first 2 days. Unless you had something to go by, that he had a poor capillary refill, he was very toxic, he had sepsis, then you naturally knew to quickly go through investigation. But if he did not have anything, I think fever has never killed anybody, but doing something wrong has killed few people. And I think these protocols are very, very important. Same way, now we know that if you diagnose UTI, you have to proceed further in a big way, even if the child looks too good and you know all investigation and prophylaxis, etc. When it comes to a recurrent UTI or a recurrent pneumonia, or for that matter rarely a recurrent meningitis, everybody wakes up and says there's something wrong somewhere. But when it's a recurrent URTI, they say everybody gets that in India. You don't get recurrent bacterial URTI. You may get a recurrent viral infection, but if you had a bacterial URTI, which means you thought every time you prescribed an antibiotic, I think you have to search the background cause. And every URTI has a background cause. If it's bacterial, if it repeats, and therefore there is no question of giving every month an antibiotic, saying that, oh, everyone gets a URTI. In India, we can blame URTI to every season. And now the rains have started, so you have a URTI. And in the winter, you have an URTI itself. And therefore, I feel these are standard rules. But in a hurry, you would see everyone being prescribed antibiotic month after month, least realizing that this URTI has to have a background cause. You have an unresponsive pneumonia, before you change an antibiotic, look at an empyema, which is the commonest cause, and changing antibiotics would never work. We know all these rules, but we often tend to push something else instead. We know asthma in infancy is never an asthma to be taken for granted. You have some background cause like maybe a GR or a CF or whatever. We know very much that neonatal jaundice by 2 weeks must be investigated to find out a proper cause, and I think that's the time that you are in a hurry to diagnose the condition. And a short station, we already said, nothing better than a longitudinal growth chart which gives you an idea. And if you had a bilateral cryptorchism in a full-term baby, I think refer to Dr. Raghupati. I'm sure he agrees that you don't have to have ignoring this fact, barring a preterm baby, yes. But if you have a bilateral cryptorchism, now these are all the rules, and there are many rules of the game which have been wisely protocoled over years. We know them well. Somehow we don't often follow them, and we take them leisurely. As Dr. Raghupati mentioned, a child with pubic hair development and still not looked in.